The medical management of non-ST elevation myocardial infarction hinges on rapid risk stratification, optimal antithrombotic therapy, and determining the appropriate timing for an invasive strategy. The current approach, heavily informed by the 2023 ESC guidelines for the management of acute coronary syndrome and ACC/AHA guidelines, focuses on a rapid rule-in rule-out algorithm and tailoring intervention to risk profiles. Initial assessment and risk stratification. The cornerstone of modern NSTEMI diagnosis is the use of high-sensitivity cardiac troponin assays. 0-1 hour or 0-2 hour algorithms utilized for rapid rule-in or rule-out based on baseline levels and absolute changes within the first 1 to 2 hours. That was something which is called as delta troponin. Risk scoring. The Gray's risk score remains the standard for objectively assessing mortality risk and guiding the timing of invasive management. Pharmacological therapy. Medical management prioritizes balancing ischemia resolution with bleeding risk. Anti-ischemic therapy. Nitrates. Sublingual or intravenous nitroglycerin for ongoing ischemic pain. Avoid if systolic BP is less than 90 mm of mercury or if phosphodiesterase type 5 inhibitors were recently used. Beta blockers. Initiate early within 24 hours in patients without contraindications like cardiogenic shock, active heart failure, PR interval more than 0.24 seconds. Calcium channel blockers, non-dihydropyridine, verapamil or diltiazem are indicated for recurrent ischemia if beta blockers are contraindicated, provided there is no severe left ventricular dysfunction. Dual antiplatelet therapy consisting of aspirin and a potent P2Y12 inhibitor is standard. Aspirin, loading dose followed by a maintenance dose. P2Y12 inhibitors, prasugrel or ticagrelor are preferred over clopidogrel. Note on pre-treatment. Routine pre-treatment with a P2Y12 receptor inhibitor in NSTEMI patients whose coronary anatomy is not known and who are scheduled for an early invasive management is not recommended by the latest ESC guidelines due to increased bleeding risk without ischemic benefit. Parenteral anticoagulation is recommended for all patients at the time of diagnosis and should be discontinued immediately after PCA in those without an indication for long-term oral anticoagulation. Unfractionated heparin needs a weight-adjusted IV bolus. Enoxaparin subcutaneously every 12 hours. Fondaparinux subcutaneously daily but requires unfractionated heparin bolus during PCI to prevent catheter thrombosis. Bivalirudin, considered as an alternative to unfractionated heparin, particularly in patients with a high bleeding risk or a history of heparin-induced thrombocytopenia. The decision and timing for coronary angiography depends entirely on the patient's clinical risk profile. Very high risk, hemodynamic instability, cardiogenic shock, recurrent refractory chest pain despite medical therapy, life-threatening arrhythmias, mechanical complications, acute heart failure. For them, it is immediate within 2 hours. High risk, confirmed diagnosis of NSTEMI, that is HS troponin, dynamic ST or T wave changes, Gray score more than 140. Early angiography, that is within 24 hours. Low risk, none of the above high risk features, symptoms stabilized, selective angiography or non-invasive testing. Post-discharge management requires a lifetime management strategy to prevent recurrence. Lipid lowering, high intensity statins initiated early to target LDL cholesterol less than 55 milligrams per deciliter and a reduction of more than or equal to 50% from baseline. Ezetimibe or PCSK9 inhibitors are added if targets are not met. ACE inhibitor or ARB indicated for patients with heart failure, left ventricular ejection fraction 40% or less, diabetes, or CKD with due precautions. Mineralocorticoid receptor antagonists for patients with LVEF 40% or less and heart failure or diabetes, provided no significant renal failure or hyperkalemia.